Okay, good afternoon, everybody. I hope you can hear me. I can't hear or see you, so I believe there are plenty of you there. So great to have you here this afternoon. Welcome back to those of you that were here for the morning. We had a really good session, some fabulous talks. Nev Jones was the highlight for me, as I'm sure it was for many. And if you weren't there for that, I advise you to see the recording, which will be available after the day. So all I'm going to do is welcome you here this afternoon. We've got a great programme of speakers this afternoon. We're going on through to 3 o'clock. There is some housekeeping to quickly go through. If we can have the next slide, please. Okay, so you're automatically muted. We've got, I believe, hundreds of people joining, which is such an improvement on when we tried to squeeze 100 or so people into the college building. So it's great to have a lot of you here, but obviously you won't be able to ask questions verbally. If you're familiar with Teams, there is the chat function. Please do use that. Type up any questions you'd like asking, and those questions can be liked with the thumbs up feature. So that'll give us a chance to select a few questions to be verbally answered at the end of sessions if we keep to time. If not, we'll be answering questions in the chat bar, and we will endeavour to answer questions after the event. So without further ado, I would like to introduce our first speaker. Is this correct? Is it Samir speaking first? That's the screen I've got up. No, I didn't think so. I've not got the agenda, I'm afraid. So can we have the correct presentation up, and I'll introduce.
We've got Graham up first.
Graham, I think, isn't it? Okay, are we ready, Graham?
Yep. Can you see my screen now?
No, sorry.
Okay. Let's try again. Is that any better? It looks like it's sharing on my end.
Yeah, I can see your screen, but it's not on presentation mode, Graham.
Oh, okay. Sorry about that. Let me try again.
That should be working now. If you just hit play.
Is that it?
I think it's okay. We can see. Just make sure
you may have to go with it as it is, Graham, because I think we can all see it. So just to introduce Graham, who's a lecturer in psychiatry in Cambridgeshire and a consultant, and is also at the University of Cambridge. So over to you, Graham.
Well, thank you very much. Now, we had planned to do a very interactive session where I would be sharing some experience and learning a lot from you as well, but of course we've had to adapt. So what I will do is make some observations that will hopefully either be interesting or useful based upon my 15 plus years of working clinically and in research in EI, and I'll just touch on a few topics, and these will be what kind of diagnosis we see in EI, the mechanisms of psychotic symptoms, cross diagnoses, and then some practical issues on who to take onto the caseload and the role of extended assessment. So what kind of diagnoses do we see in EI? We see, here's some data from one of today's other speakers, James Kirkbride and colleagues from the SEPIA study that was 700 or so young adults up to age 35 treated in the east of England a few years ago, and that catchment area was about 5% of England. And you can see in the blue parts of the chart that the majority of diagnoses were schizophrenia or other non-affective psychosis, with only about 9% bipolar and 3% psychotic depression, so 12% affective psychosis in that sample. And then another sample, again from James Cabride's group, this time Hannah Youngsma et al. In the EUGI study, which is an international study, actually larger study, and importantly going up to age 64, age inclusive. So there, when you go to age inclusivity, you can expect to see some more affective psychosis, because that's more common as a presentation in the older age groups. They're about a fifth of the conditions were meeting criteria for affective psychosis. And if your service has gone to age inclusive over recent years, then you may have noticed an increase in the amount of affective psychosis that you're managing. Okay, so those are the, and of course we know that diagnoses do change over time, but it's the positive psychotic symptoms that are often one of the key entry points to EIP services. And it's interesting to ask the question as to whether the mechanisms of psychotic symptoms are the same or different across diagnoses. And actually there's a lot we don't know about that, but thankfully we do know some things, such as, for example, this important study from another one of today's speakers, Dr. Johar, who showed a couple of years ago with colleagues that some of the dopaminergic abnormalities that we're familiar with in schizophrenia psychosis are also present in bipolar psychosis. So that's important biological result. And it leads, I think, but of course, as usual, you find one thing and that leads to another question. And an important related question is, can we understand what's going on in the biology, what's going on in the brain, and can we link that at a deep level of understanding or a satisfactory level of understanding of the kind of mental experiences that characterize psychosis? And
sorry, Graham,
yeah,
we just had to share slides outside because yours weren't clicking next, so if you could just let us know which slide.
Oh, sorry, thank you. Okay, so if you can go to the slide, so I'll stop sharing my screen in that case. So if we go to, so this slide is fine. Yeah, so one of the theories that has been proposed to be possibly able to reconcile the biology and the psychology of psychosis relates to this idea of the brain and the mind as kind of predictive engines, where we're constantly updating our model of the world, our beliefs when we receive new or surprising information, and then we take that new information on board and update our beliefs accordingly. And this is a very influential theory in psychology and neuroscience, and a refinement of that theory in recent years is that we need to take into account the background level of uncertainty in the environment when we're updating our beliefs. That's actually been proposed as possibly being important by Carl Friston, who you may have come across as a member of the Independent SAGE panel, but for most of his career, he's been working on the brain and the mind and the biology and the psychology of psychosis. And there may be a role for dopamine in doing this process of taking into account the background level of uncertainty when we update our beliefs. And the idea there is if we're in a very uncertain environment, if we get some new information, if we're uncertain of everything, it may be unwise to update our beliefs because it could just be random noise. But when we're more certain of our environment and we get some new information, it could be important to update our beliefs. Things may have changed. And then recently with colleagues, Kelly Diederen from King's and Joost Haarsma from Cambridge, who's now at UCL, Joost showed that in first episode psychosis, there are problems in tuning the right degree of updating one's beliefs according to the degree of the uncertainty in the environment. And this may relate to dopamine signaling. And there's a region in the superior part of the brain, the superior frontal cortex, where the degree of brain signaling abnormality linked to the degree of psychotic symptoms in people with first episode psychosis and ARMS. So next slide, please. So of course there's a lot to that, but the take home really is that it may be in psychosis there are problems in the way that the brain uses dopamine to process surprising or new information, and how well it tunes belief updating according to the uncertainty of the environment. And there's more information on that on the paper that was published last week. And then if you like podcasts, there's the Naked Scientists are doing a podcast on this, BBC, very good BBC Science podcast. That should come out either later today or tomorrow. Next slide, please. Now, we know that psychotic experiences can actually, now we know that they can occur in any mental disorder and in the healthy population. I think that's been increasingly clear in the research over the last 20 years or so. And a few years ago, you can see I published a paper with Peter Jones in the British Journal of Psychiatry in 2012. And when you publish a paper in the British Journal of Psychiatry, an editorial, they publish a picture of you, so you can see how much I've aged in these recent years. But we wrote an article thinking about the increasing evidence about psychotic symptoms occurring across disorders and in the population. And then I found out, of course, that there's nothing in EIP that hasn't already been said, and said better usually by Professor Joe Smith, who wrote in 2008 that we need to be careful about pathologizing all psychotic experience as indicative of emerging first episode psychosis. Next slide, please. But it's important, isn't it? Because I think we're aware, once we take people onto the caseload, we're very aware as clinicians that diagnoses can change, and we need to be mindful of that. But a key categorical decision is, do you take somebody on to the caseload? Next slide, please. And so in an article that was led by Joe on behalf of NIMHE, an organisation that has been sort of incorporated into other organisations now, the National Institute for Mental Health England guidance on early intervention acceptance criteria, very, very useful documents, hard to track down now. I think it could be good, if possible, if we could get it up on the IRIS website. I find it very useful. And in it, Professor Smith and colleagues consider a number of different instances of where there could be some debate about whether to take a patient on to EI caseload, and cover the important issue of psychosis in borderline EUPD type presentations. And of course, I think it's right that we will, all of us, have one or two or a handful of these type of presentations or cases on our patients with these kind of presentations on our caseload. And I think that is right, that we should have some, of course, because EUPD can be comorbid with other conditions such as schizophrenia or bipolar, etc. And then, of course, there are other times when, if you want to cast your net sufficiently wide that you don't miss emerging first episode psychosis, but you also, as pointed out in this document, need to be careful about just how wide you cast your net, because you need to consider the impact on overall service delivery if the entry criteria to your service are too flexible, and in particular the expertise required to effectively treat presentations like borderline EUPD. It's pretty different to maybe the majority of the work in EIP, where one is typically aiming to assertively outreach to engage the under-engaged, contrasting maybe with some conditions where over-engagement can be a problem. So getting that balance right is challenging. So how can we do that in the initial assessment? Next slide, please. So just some simple tips in doing an assessment. And this seems such a simple tip, but it's one that I find useful, which is to, when you're not sure, when you know it's going to be a difficult assessment, or you think there's going to be an important differential that you want to cover, take a list of questions or a list of diagnostic criteria into the assessment with you. If you can't remember, if like me, you can't remember the diagnostic criteria for EUPD, take it in with you. Maybe not with a big capital of what it is, but just the list of things that you want to cover in the assessment, or if there's some other condition, PTSD, or you're not sure about ARMS or FET, take some questions in with you as an aid memoir, and I find that useful. Now, there's an interesting study that I've shown there on the slide from European Psychiatry a few years ago from Guy Goodwin and colleagues, when in Oxfordshire they studied psychiatrists as they were trying to distinguish bipolar disorder from borderline personality disorder. And these psychiatrists, well-trained, experienced psychiatrists who were aware that they were being studied as to how they make a diagnosis. And even then, they would make diagnoses without eliciting all the information that was really required to make the diagnosis. And I'm sure I've done this, many of us have done this, but it's good to try and not do this. And so a good way to try and help make sure you ask the right questions is to take a list of questions in with you, and then it's less likely that you will forget to ask them. Of course, sometimes you still will forget to ask them, and then you can discuss with colleagues, and of course you can arrange to see the patient again. But if you take that list in with you, less chance of forgetting. Next slide, please. So I think another very useful document is one that is up on the IRIS website, which is this guidance clarifying referral criteria produced by NHS England North, early intervention in psychosis, pointing out that if psychosis is not the primary problem that needs care, then EIP teams may feel it's appropriate to refer to another more appropriate specialist service, say drug and alcohol, autism, if you're lucky enough to have an autism service in your area, or personality disorder service, etc. So what's the primary problem? Okay, yes, there is psychosis there, but is it the main problem? And of course, there's also a role for CMHTs in many cases. So, just one example could be in people with chronic affective disorder who develop a single psychotic episode in middle age. Then does it really make sense to pull those people out of CMHTs and bring them into EIP? Can be a difficult decision to make, but I think just thinking through what is the main problem can be helpful. Okay, next slide, please. Now, one thing that has been proposed to try and be helpful is to do an extended assessment. So in my service, extended assessment is a period of care coordination and treatment for up to 6 months. So we take the patient on, we are delivering care, but we're thinking, are we the right service for this patient? And so we don't, as we would normally do, we don't say, look, we're going to be treating you for 3 years. We say, look, we're going to be treating you and supporting you, and we're going to be doing that over the coming months. And the idea of this, I suppose, is that, after a few months, you can think, well, maybe the other service was better, and you can try and refer the patient on to a more appropriate service. Next slide, please. But does this actually make any difference? So looking at data from our service, Cameo, EI service in Cambridgeshire and Peterborough, out of 800 or so referrals over recent years, of those we took on, 3/4 we took on just for standard care, and about 1/4 we used this extended assessment category. So quite a chunk. Let's see if it made any difference in the actual amount of time, because the idea is it helps you move people on to more appropriate services if needed. So next slide, please. Here we've plotted the duration of time that people spend with our service. So some of this time we were a 2-year service, and not everybody spends 2 years with the service because, of course, people move out of area or it's appropriate to discharge them. But in blue, we have the standard pathway, where on average we're following people up for about 13 months, and extended assessment is more or less the same on average. If you look at the median on the On the right-hand side, then that's a little bit less, both for standard and extended assessment. So the median is dragged down a little bit compared to the mean because there are quite a few people who move out of area. You know, they get unwell, maybe a young person moves back to their parents in another part of the country or abroad if they're studying, for example, or working temporarily in the country. So the median is just under a year for the standard pathway and under 9 months for the extended assessment. So the extended assessment, next slide please, it does provide something. I think it's very useful. As a clinician, I find it useful to help think through my work, but actually at a sort of team organizational level, it doesn't actually save that much work because on average, the patients on extended assessments spend about the same amount of time with the team, only just slightly less than the average patient. Okay, next slide, please. Okay, so just to wrap up, we've covered that it's mainly schizophrenia spectrum psychosis in first episode EI teams. The ratio of effective and non-effective psychosis could be different in different age groups and whether you're an age-inclusive service or not. I do think more knowledge about mechanisms could hopefully help us improve treatments in the future. So that's work for the future. But currently, thinking flexibly about what is the main problem and the most appropriate service in your trust or area is a good thing to do about entry to the service. Because I think once people are in the service, then we can be flexible, but that is a key decision, isn't it? So getting that initial assessment right, using a checklist if possible, or if you need to, and then extended assessment can be part of a flexible assessment. Although bear in mind, it won't be, at least in our data, it's not really having a large effect on overall teamwork. Next slide, please. So I just want to thank all of my colleagues and patients at Cameo, especially Arti Kudchadkar for the data management, and then Joost and Kelly on the research side, as well as many, many others. And thank you very much for listening.
Fantastic. Thank you, Graham. Not bad timekeeping either. We faffed about a little bit at the beginning. I do apologise. The technology is not quite with us. Going to take time for just perhaps one question, Graham. So some of the comments were kind of existential. So right next to each other, two people asked, firstly, what is the risk of everything being considered possible first episode psychosis? And then secondly, what is the risk of pathologizing experiences as psychotic? And then the question I want to pick up on is, do you think multidisciplinary formulation approach to assessments helps?
I certainly do find that. I mean, I will often see, I will really value seeing a patient initial assessment with a colleague from a different background. It's good to see a patient with another psychiatrist, but I often find that I think the same as another psychiatrist about, being trained in similar ways. So we tend to come up with similar conclusions. But if I do an assessment with a psychologist or a nurse or a social worker or an OT, etc., then I get a different way of thinking. So even after all these years, I can still learn a lot, definitely, especially from colleagues from different backgrounds.
Okay, lovely. Thank you. And there are more questions, so hopefully you'll be able to have a look at those for us as well. Going to move on now onto the agenda to the next presentation, which is a joint presentation by Samir Dahoa and Rachel Upthegrove, who both work in Birmingham. So I believe, Samir, you're going to start. So can we hand over to you, please?
Thank you. Can you hear me clearly?
Yes.
Great. Just going through the slides. So it's Samir Johar. Thank you very much. I work in London at the Institute of Psychiatry, and I've covered all the lovely boroughs in southeast London, from Lambeth, Southwark, Lewisham to Croydon. These are my declarations of interest. Is it going through okay? Slides? Are the slides progressing okay when I press?
Yes.
Can I just, so when I've pressed there, has that come through? So these are my declarations of interest. I've given talks for Synovian on my dopamine data, on my imaging, My employer's got paid for talks I've given, which has been good for my employer. And I've been a co-investigator for a study that hasn't recruited any patients. What I'm going to cover are the basics. Antipsychotic response that we see for people, a little bit of theory behind them. I think what's more important in these sort of meetings is to get people to reflect. And I guess give people a space to reflect on their own thoughts, because what I've learned, but Nev was great, Vina was great, Graham was obviously great there, but people being able to reflect on their own experience of what they do, because you all work as clinicians, you've all got a lot of experience, and I think it's just presenting that across. So I can hopefully go through some of that. These are the papers I think that are relevant, and let's just go through it. So what is antipsychotic response in first episode? I would say it's good in people with first episode non-affective psychosis. What do I mean by response? I'm from Glasgow, and if you were to ask your grandmother, is this person better? I would say that's a good response. And I think for patients and their families, you ask them, and they'll say, being able to get on with my life, functioning. If I go on a bus, no one's going to know that I'm unwell and that I'm able to get on with my life. So a big improvement. When we use scales, you can see 50% improvement on a scale. And essentially this was shown and borne out by the Optimize study, a big randomized controlled trial across Europe. People with first episode illness were offered antipsychotic medication, amisulpride, for 4 weeks. And then if they were not in remission, the illness was not in remission, they got offered either continuing with amisulpride or a switch to olanzapine. And essentially, take-home message from the study, 70% of people have a good response. So significant response to antipsychotic medication. And that also mimics what we know in the epidemiology. 20% of people will not have a good response, and that will be there from really the beginning of the illness. And I think that's the important point to put across. My slides have gone funny. Where are we at on the slides? For some reason. Can I just check what is it on Optimize, and it's come off Optimize onto minimum effective dose. So when we're going through dosing studies, and I guess this is the important thing about working in EI, it's important to think what the minimum dose is for someone and to offer someone, because the last thing you want with a young person is for them to be taking medicine, getting side effects when you don't really need them. So I came up with this table, and I think what's important to bear in mind when you look at it is the minimum effective dose that people get offered. And when you look at the data, a lot of people, I think in the UK, get offered doses that are far too high in comparison to that. And you do not need high doses of medicine to have a significant response. And if you go through that, I think aripiprazole is one of the medicines that's offered. 10 milligrams, you don't need higher than that. And biologically, you don't need higher than that. So coming on to the biology of antipsychotics, the reason I've put this slide up is it reminds me how old these hypotheses are. And that's from the Natural History Museum. And that I thought was a dinosaur. Apparently it's a bear, but it tells you how old the hypothesis is of the dopamine hypothesis. The theory that certain drugs, when given, will cause an increase in dopamine synthesis or dopamine release. And in some people that will cause positive psychotic symptoms. That was seen in housewives who were offered dexedrine or amphetamine, or taking that in the 50s and 60s. It's a bad example of misogyny there, where they would then get some positive psychotic symptoms in the context of taking those substances. There were various experiments done where people were offered or given significant doses of amphetamine, and you were able to recreate positive symptoms with amphetamine. I put this slide up there of Paul Janssen because people think that the way that antipsychotics were discovered or used is all serendipity. Not really. Paul Janssen was able to see in cyclists that they had an amphetamine-induced psychosis, and with a small dose of haloperidol, you were able to block that and lead to most of the positive symptoms going for people. It's also a reminder, his first patient got offered a dose of medicine at 1 milligram of haloperidol and was able to get on with his life, go to university and the rest of it. It is a sobering reminder that you do not need high doses of medicine to help people. I've put this slide up because sometimes there is a dichotomy between what people think of as treatment and psychosocial interventions. There isn't. With the molecular imaging, we can only explain about 30% of the variability and suggest that there's something happening with the dopamine system. So I think you need to be quite humble when you look at the biological basis of what we do. And that's what I tend to do in my work. I'll scoot through these slides, but that's an interesting study that we did do, suggesting that when you look at the dopamine system in people with first episode psychosis, people who get a response tend to have a dopamine system that appears to be overactive to a degree compared to the people who don't have a response. So there's some biological basis for what's going on there. So how long would you continue taking antipsychotics for before, or offering them to someone before you change? Say at least 4 to 6 weeks when you look at the evidence. And from what you saw from the optimized study was it doesn't really matter which medicine it is. It's just for an adequate period of time and checking that someone's actually taking the medicine. We've got criteria for resistance. You can all look that up in your own time. I think the most important sobering thing for me there is that a lot of people don't take the medicine, and you have to ask yourself why. And you need to listen to your patients and their families about that, because a lot of people, when I covered a treatment resistance clinic starting clozapine in the community, about 50% of people when we took antipsychotic levels weren't taking antipsychotics. So I think that brings us on to clozapine. And when you offer clozapine in first episode, I think it's the big message for everyone. You start at a low dose and you let the person dictate their dose. I set up a community clozapine service, and that's what we tended to do. And it worked well with young people. There was no rush at all. And you ask about the adverse effects and let them make a decision whether they continue it or not. Fears about clozapine, it's dangerous. It is like any medicine. It'll make me fat. All the side effects. With the right people, and you let the person make the decision, our experience has been that it's been a positive step. I think the important thing in medicine is that you can also stop a medicine if it doesn't help someone, or give them the option to, and work with them in regard to that. So that brings us on to choice of treatment. And I guess when you look at the literature, these are the three things that seem to affect people's choice. Efficacy or effectiveness, so whether a medicine works or not, the side effects, and the cost. We did a study when I was young in 2012 with European psychiatry trainees. We gave them a questionnaire, a scenario of a patient, and said, if a patient came to you, what medicine would you offer and what would affect your decision making? We then asked them, well, what would you choose for yourselves? And they didn't know that question was coming. And what was sobering was that doctors chose different treatments for themselves and their patients based on things such as weight gain. They were more likely to prescribe olanzapine, for example, for their patients and aripiprazole for themselves. So that gets you thinking. I'm fortunate in the IOP to share an office with Toby, who did a really nice meta-analysis on weight gain. And coming back to what we're talking about medicines and presenting the data on diabetes, look at the red there. The red there suggests medicines that are metabolically not very good for people. And I think that's something we need to be cognizant of and aware of with our patients, because if we get a good antipsychotic response with most treatments, we get a good antipsychotic response, it shouldn't really matter which D2 blocker you're offering to someone. And I think from my own perspective, I don't think olanzapine should be as widely used in maintenance treatment as it is. And lastly, when you reflect on what we do, none of us live in a bubble. We live in society. I look after people predominantly of non-white background. I'm an Asian person. And when you look at pharmacology, it is so individual. Different people have weight gain, different people have side effects. Extrapyramidal side effects you see a lot in a lot of people from different backgrounds. I think I've seen myself, you do not need high doses of medicine, but I've seen in Afro-Caribbean patients, Asian patients, increased weight gain, increased sensitivity to EPS in a lot of my Black patients. And I think just like we do it in our everyday approach for psychosocial interventions, we should be doing that with pharmacology. We should be thinking of the individual person and giving them that freedom to think about the treatment that's best for them and individualizing it. So in summary, I've tried to do this in 8 minutes. I've hopefully succeeded. There is a biological basis for antipsychotics. Antipsychotic response is good for people with first episode illness. But I think the real skill, and the skill that we should be doing, and I think a lot of people do, is tailoring treatment for the individual person and working with them and letting them make an educated decision. Because let's be honest, young people, they're going to do what they want, and that's the way things should be. So thank you for your time, and I'll leave you with Professor De Grove. Thank you.
Thanks very much, Samir. I'm hoping you should be able to see my screen coming through in a moment, but it was just playing up.
Great.
So, yeah, here we go. Are you seeing that now? Yeah. Is that on presentation mode? Good. Okay, so first slide, next slide on outline. What I'm going to be talking about today is just taking on a little bit from what Graham was talking before about diagnostic uncertainty and staging. I'm going to talk a little bit about some non-dopaminergic targets of therapy. So really talking about what we can do with medicines in first episode psychosis, whilst recognising that it's only one part of treatment we should be offering. I'm going to talk about two sort of novel areas for new treatments that we may see more of in the future. Next slide, please. Just going on to the staging model. Yep, are you seeing that?
Sorry, Rachel. I don't think it's gone into presentation mode.
So are you sharing my slides?
No, you are.
Okay.
But if it's not working, we can share my side.
Sorry, I thought you'd taken over. I had a signal that you'd taken over. So could you take over?
Yeah, no problem.
Yeah, so you should be on the third slide. Wonderful. Okay, good. So I think most of us are accepting that early intervention is part of a staging model of mental health care for psychosis. And most people who come into an early intervention service are within the second and third stages. And when people write about this, they generally say that medication is part of that. But of course, what do we mean by medication? Do we mean antipsychotic medication? How long? What else might we be able to do with pharmaceutical treatments? And how do we actually make that just medication stage much more fine-tuned, as we would do in other branches of medicine? And again, I'm talking as a psychiatrist, within different stages approach, this idea about medication would be much more fine-grained, echoing a little bit what Samir was saying before. Next slide, please. And so again, this is just emphasizing this staging model even more. So if we have stage 2 and stage 3 is where we want to be thinking about medication. What medication should we be giving? How long? For who? Who should be on longer term antipsychotic medication? And other options to consider. Next slide, please. And again. So one of the things that I've been interested in for over a decade now is the idea of effective symptoms in first episode psychosis and the importance they bring. So this is a longitudinal cohort study we did over 10 years ago now in the Birmingham service. And the thing to focus on really is the yellow line at the bottom. So we charted the experience of depression through first episode psychosis, and we see that the vast majority of people, so 80% of people, had a clinically significant depressive episode, either in the prodrome, the acute or post-psychotic phases, or throughout. So depression and depressive comorbidity, rather than being a subgroup or a small selected group, is an experience that the majority of people will have. Next slide, please. And that depression is actually one of the most significant predictors of poor outcomes, whether they mean by poor outcomes a poor functional recovery, whether we mean relapse, so depression in the first episode is a predictor of subsequent relapse, and of course a significant risk factor for suicide. So Rena Dutta and others are really focused on this even more than we have, which will show that although the risk of suicide in psychosis is significant and extends through the lifetime, the risk is highest within the first year after presentation, and depression and depressive cognitions are really important in that prediction. Next slide. Over and above depression, anxiety disorders are also really frequently comorbid. So again, this is work from the Birmingham group with Kat and Max and other folk here, charting the frequency of social anxiety and post-traumatic stress disorder symptoms after first episode psychosis. And again, these studies were generally cross-sectional. And if we were to look at the longitudinal presentation of trauma or PTSD and social anxiety and anxiety disorders, these are likely to be even more frequent. Next slide, please. So my main message, I think, of this talk is that actually we don't need to think so much about fancy new pharmaceuticals. We can use what we already have and really address the idea and the prevalence of comorbidity to try and improve outcomes and not just focus on the positive symptoms and antipsychotics. So this is some work that we've done, again, which showed the effectiveness of antidepressant treatments in treating depression in first episode psychosis. So the top slide, you'll see a nice little chart here which shows that antidepressants, and these are usually SSRIs, can be effective in schizophrenia and effective in treating depression within schizophrenia, with a number needed to treat of 5, which is really pretty about as good as you can get in intervention studies. And also the second paper, which I'd recommend, by Tiho et al., big, large Finnish population-based studies showed that polypharmacy with antipsychotics, antidepressants and benzodiazepines really is a mixed picture. And if you focus in the bottom left-hand corner, what we see is that patients who are co-prescribed an antidepressant and an antipsychotic have an overall reduced all-cause mortality compared to those who are not co-prescribed. The real message is that co-prescribing benzodiazepines in people with psychosis and schizophrenia is an increased risk and something that we should probably avoid. Next slide, please. Not wanting to go too much into CBT because I really don't have time today, but just to say one of my enduring frustrations is that despite the mixed or evidence about CBT and psychosis, no studies that have looked at CBT in first episode psychosis have had depression or anxiety as a primary outcome or target of therapy, which means we really don't know whether CBT works for comorbid depression or anxiety disorders in psychosis. Secondary analysis of secondary outcome measures shows a moderate or weak effect, but these studies are not powered to address the question of whether CBT works for depression and psychosis. But if I talk to my psychology colleagues and the patients I refer for CBT, the focus of therapy is often things that we know are depressive cognition, so shame, loss, the humiliation, entrapment, all of these things that really are impeding functional recovery are in keeping with a depressive and affective picture, rather than the focus being primarily on the positive symptoms. Next slide, please. And just a final note that, of course, whenever we're talking about comorbidity and polypharmacy, that this needs to be done with appropriate monitoring, particularly if you're talking about higher doses and sometimes if some combinations of antipsychotic and antidepressant medications. But we really want to think about these individual patient trials, and if they don't help, don't continue. Next slide, please. So finally, in this part, finally in summary, so depression, think about it, monitor for it. Antidepressants are likely to be effective. Individual patient trials, avoid haloperidol. I really don't have time to go into why this is, but it is potentially depressogenic. And if I was going to be prescribed an antipsychotic in first episode, I would not be using haloperidol. And anxiety, again, really assess and monitor for PTSD and anxiety. These can be early signs of relapse, and avoid benzodiazepines. Next slide, please. So really quickly, because I think I'm going over time. Next slide, I'll skip over that. This is a trial we're going to be starting. So next slide, please. So there are some new, some new really non-dopaminergic targets for therapy. Samir would probably be able to answer more questions about TAR and CEP363. But what this is a non-dopaminergic target of therapy. Widely TAR receptors are widely distributed to the CNS, and there's some candidate non-dopaminergic molecules that we know actually affect downstream the firing of dopaminergic neurons. So what this study here is in an animal model shows that CEP doesn't bind to D2 receptors, but it does have an antipsychotic effect in a mouse model. Next slide, please. And this was the first phase 2 trial that was published earlier on this year, which showed a significant effect on positive symptoms and negative symptoms of patients with schizophrenia. Relatively large numbers completed the trial, and relatively equal numbers of dropouts and side effect profiles to placebo. So some promising evidence for this new non-dopaminergic antipsychotic. Watch this space. Next slide, please. And then, of course, one of the other things that I've been interested in for quite some time is immune targets in schizophrenia. This diagram just shows lots of different ways in which the immune system can directly impact the brain through activation of microglia, signal transduction pathways into the glutamatergic system. Next slide, please. And we know that immune targets are effective in treatment-resistant comorbid depression and negative symptoms. So these are potential targets for immune modulating agents because we've seen an increased inflammatory signal in these subgroups. Next slide, please. Keep flicking through till we get through. So, there we go. But of course, most of you will know that the Minocycline trial, which was a definitive trial of minocycline in schizophrenia targeting negative symptoms, was negative. So we do have quite a bit of work still to go before we find effective immunologically modulating treatments in schizophrenia. Next slide, please. And again, I'm skipping through. And that might be because we're not really targeting anti-inflammatory agents early enough or to the right symptom profile. So this is a Cochrane review that we're just completing at the moment, which showed overall that celecoxib, which is an anti-inflammatory agent, wasn't effective in schizophrenia. But if we looked at the really early studies, so first episode psychosis and very, very early response, there was some signal. So I think the message is here that we need to be really looking at subgroups of patients with inflammatory profiles, or really tailoring our medication to those people who are most likely to respond. Next slide, please. So in summary, we have existing non-dopaminergic treatments available if we just monitor and look out for depression and anxiety-related comorbidities. SSRIs will be worthwhile trying in people who haven't made a really good functional recovery. Avoid benzodiazepines, I think, is a really clear message. Definitive trials are still needed, but they are underway and starting soon, one of which we're running here from Birmingham. There are other targets, TAR, for example, and the immune system are somewhat farther off, but still promising. And I think that while we have such a wealth of treatments and services targeting people with first episode psychosis, we really need to match that with individualized and personalized treatment, and that needs more investment for research and funding into finding out which are going to be the best treatments for the best person. And that's me. Thanks very much, and sorry to run over time.
Lovely. Thank you, Rachel. Thank you, Samir. We are a bit over time now. I've been monitoring the questions, some very sophisticated questions coming through, which I've noticed Samir's already answering. So thank you for doing that. I won't take any verbal questions, just so we can try and keep on time, but thank you again. So our next speaker this afternoon is Emily Peckham, who is a research fellow at the University of York, and she's going to talk about smoking cessation and the Why Quit initiative.
Hi, I'm just going to try and share my screen. Hopefully everybody can see this all right. So let me know if you can't see the slides and if they don't forward. So my name's Dr. Emily Peckham. I work at the University of York, and I'm going to talk to you about Why Quit, which stands for Youth Quit, and smoking cessation. So, okay, so next. So I'll just give you a little bit of background about the work that we've done around smoking cessation at the University of York, and tell you a bit about our SCIMITAR programme, which is a bespoke smoking cessation intervention for people with severe mental ill health, so people with things, illnesses such as psychosis. And then I'll talk to you a bit about Why Quit and the future in terms of what we're hoping to do as we move forward. So just a quick slide about smoking in people with severe mental illness and in the general population. I'm sure you all know this anyway, but smoking is much more prevalent among people with severe mental illness. As you can see from this slide, 40.5% of people smoke compared to around 14 to 15% of the general population. And a third of all cigarettes smoked are smoked by people with a mental health problem. So that's quite a startling statistic, and that's where we began our work and why we decided to try and tackle smoking cessation in this area. So one of the myths around smoking cessation in people with SMI are that they're not interested in quitting smoking. And we've recently carried out a survey of around 8,000 people. And in this survey, we asked people about whether or not they smoked, and 42% of the people we surveyed smoked. And we also asked those people who smoked, do you want to do anything about your smoking? Do you want to cut down or quit? And we found that 3 in 5 people wanted to quit smoking. So that if you asked people in the general population, do you want to stop smoking, you get a similar figure of people who wanted to do something about their smoking. So we realised that people do want to do something about their smoking, but they need some support to help them. And so we also decided to ask people about why they smoke, to try and understand a bit more about, if we were going to help people to stop smoking, what we needed to do and how we could best help them. So in general population surveys, the most commonly reported motives for smoking are people enjoying smoking, they enjoy being a smoker, and stress relief. So we conducted a pilot study around smoking cessation, and as part of the pilot study, we asked people about why they smoked. And the most commonly reported reasons were, it helps me to cope with stress and it helps me to relax. So very much similar to the reasons reported within the general population. But then something that was slightly different to what people have tended to find in the general population was that people said it's something to do when I'm bored. And that was 86% of our participants said that. So we realised that in trying to help people to stop smoking, we needed to think about ways to help people find activities other than smoking when they were bored. So other things that they could do instead of reaching for a cigarette when they found themselves bored. So thinking about these things, we then went on to find out what worked and what we thought, how we could then adapt interventions that currently worked to make them more suitable for people with SMI. So we did a systematic review. We found the same things that worked for the general population can work for people with SMI, and that if participants were psychiatrically stable at the initiation of their quit attempts, i.e. they were not in a crisis situation, smoking cessation interventions didn't worsen their mental state. And in addition, a recent systematic review found that there was no increase in psychiatric symptoms in participants prescribed varenicline, which is one of the most commonly used smoking cessation medications in the general population, also known as Champix. So we looked at what worked, we looked at what people had said to us about why they smoked, and then we looked at the National Centre for Smoking Cessation and Training Standard Treatment Protocol, and we then adapted that to what we'd discovered from our systematic review, what we'd discovered from what people had told us, to make it suitable and to tailor it for people with SMI. So one of the things that people were particularly keen on was having an intervention that was delivered by somebody who understood them and understood the particular challenges that they faced. So to do this, instead of having a smoking cessation advisor who had a bit of knowledge of mental health, we trained up people with knowledge of mental health who worked within mental health services to be a smoking cessation advisor. So we trained CPNs and people support time and recovery workers in smoking cessation, and we trained them to level 2 of the National Centre of Smoking Cessation and Training's smoking cessation programme. So, and we found that participants in our studies really liked this. They really benefited from the fact that they felt that somebody who was explaining the smoking cessation, supporting them to make a quit attempt, really understood the particular challenges that they might face. So they provided behavioural support to the person who wanted to stop smoking. And in our model, we don't try and make people stop smoking. We only invited people to come into our studies who wanted to do something about smoking. So we're not trying to change people's minds about smoking. We were trying to work with people who wanted some support to help them stop smoking. So people were provided with behavioural support and also nicotine replacement therapy as the mainstay of treatment. Although if somebody wanted to be prescribed varenicline, then we would try and support them to do so. But in the main, we helped people to be prescribed nicotine replacement therapy. And we would recommend 2 forms of nicotine replacement therapy. And our mantra was that people should receive as much NRT as they wanted for as long as they wanted. And that was the way that we'd be able to help people most likely make a sustained quit attempt. So just a little bit more about our intervention. So in standard treatment, people would generally have an initial session with a smoking cessation advisor, and then they would set a quit attempt, which would be their next session. And then they would have 4 more sessions after their quitter date to help support them continuing to quit. So we provided some flexibility on the quit date so that people didn't necessarily need to quit on the second session. They could have 2 sessions to really get to grips and sort of feel a bit more supported and think a bit more about their quit attempt. Also, generally, people would make an abrupt quit because that's the most likely way that people are going to be able to make a sustained quit. But we found sometimes people were a bit anxious, lacked the confidence to make an abrupt quit. So we supported people in doing a cut down to quit in the hope that they would then make a full quit attempt. So a cut down to quit was structured. It wasn't just, oh, I might cut out a cigarette here and there. It would be that people would create a smoking diary where they worked out where they smoked during the day, and then they'd decide which cigarettes they were going to cut down, and they'd cut down a structured amount, say 5 cigarettes a day for a week or something like this. And as people gained in confidence in their ability to cut down on the number of cigarettes they smoked, they were then able to move forward and make a full quit attempt. We were also flexible on the venue of where people were provided the smoking cessation advice. So if people were a little bit anxious to leave their home or a bit anxious to go to somewhere unknown, then they could have the intervention would come to them. And that people really liked that and really felt that they benefited from that option, where going somewhere new was a bit too much for them, especially as giving up smoking is an anxiety producing thing anyway. We also provided support to ensure that people got the nicotine replacement therapy that they wanted. We discussed different forms of NRT with them and then what the different forms would do. And we'd recommend that they would have a patch, i.e. a long-acting form of nicotine replacement, and then a shorter-acting form for if they had a craving, such as a mouth spray or nasal spray. People could have a longer number of sessions than perhaps standard treatment would allow. So standard treatment is for 6 sessions. We allowed people up to 12 sessions. People were supplied with a support pack. And one other important thing was that psychotropic medication was managed. So we liaised with people's psychiatrists or care team to ensure that any medication management that needed to take place would take place. So that if people needed to have their psychotropic medication reduced, if they'd made a quit attempt, then that could take place. And we also, most importantly, planned for a quit attempt. So what people could do in place of smoking, and we helped people problem solve and think up activities of things that they enjoyed doing, that they would like to do instead of smoking. So instead of reaching for a cigarette, there was something else that they could do. So sometimes people enjoyed colouring, so they would do colouring or something else to do with their hands. Maybe some people took up knitting or crocheting, and some people just went out for a walk. But we just thought through with the person what kind of activity they might like to do and what they might enjoy doing instead of smoking. So I always like to show people this graph because I think this just really illustrates that people who took part in our studies were people who wanted to take part in our study and they really wanted to do something about their smoking. And so our trial was comparing a smoking cessation intervention, our bespoke smoking cessation intervention, with usual care. And we invited people to take part in this study if they wanted to do something about their smoking. And we needed to recruit 400 people in 18 months. And in fact, we recruited 526 people in 15 months. And I just feel like this slide is a testimony to the fact that people do want to do something about their smoking. They just need some additional support to help them either cut down or quit smoking. So that was the purpose of showing this graph. And you can see the bold line is the target recruitment and the dotted line is the recruitment that we achieved. So just quickly, just a quick slide to tell you a bit about the results of our study. So we recruited 526 people who were daily smokers, so they had to smoke at least 5 cigarettes per day. And we then randomised them to receive either the intervention, which I've told you about, or they received usual care. And then our outcome measure, our primary outcome measure, was whether or not people had stopped smoking, and this was biochemically measured. So we asked people, have you stopped smoking? And then we used a carbon monoxide breath measure to determine whether they'd told us the truth or not, because sometimes people, they don't want to disappoint, and they might not want to be as honest as they could be about whether or not they have indeed stopped smoking. So we measured the people's abstinence from smoking at 6 and 12 months. And at 12 months, we found that 14.2% of people receiving the intervention had stopped smoking, compared to 6.5% of people receiving usual care. And that was statistically significant. So we found that people who received our intervention were much more likely to have stopped smoking than the people who had received usual care. At 12 months, there was still a difference between the people who'd received the intervention, the people who'd received usual care, but that was less pronounced and not statistically significant. And there are various reasons we think this. One of the reasons is that some of the people, the mental health trust that we worked with, really liked the intervention and they went on to deliver it to people. And so there might have been some contamination there. So those are results of our study. So where does Why Quit come in? So what we then did was we wanted to do something for young people. And we found that in our study, generally, people who took part tended to be a little bit older, people who were 40 plus, people who were already experiencing some physical effects from smoking and decided they needed to do something about their smoking because they felt it was making them unwell and their physical health was suffering. And we didn't recruit as many people to take part in our studies from a younger age group. And we really felt that we wanted to help younger people, because if you can help people before they start experiencing physical health problems due to smoking, then we can make a big difference to their lives and their physical health moving forward. So together with our colleague, Dr. Jackie Curtis in Australia, who's done a lot of work around young people and smoking, and she's done a small scale study around helping young people to stop smoking, we created this resource which we call Why Quit. And if I was here with you in person, I'd have a whole bunch of leaflets to share with you and give out to you, and you could take them away, but unfortunately I haven't got this facility at the moment, but I will at the end of my presentation paste the link to where you can find this resource online so that you can access it for yourself. So the resource we created together is called Why Quit, Youth Quit, and it's about helping young people to stop smoking, and just helping to initiate that conversation around why they might want to stop smoking and what they might like to do if they need if they're going to stop smoking, things that can help them in their stop smoking journey, places to go for support. You know, if they're thinking about stopping smoking, there's some helpful information here. So these leaflets are available online. You can have a look at them in more detail. In the interest of time, I won't go through it all, but you can just see it's a really nice, brightly coloured leaflet to help people think about their smoking and think about what they might like to do and how they might receive help in stopping smoking. So, conclusions and the future. So many people with psychosis are concerned about the effects of smoking on their health and finances, and they would like to quit. The same strategies that work in the general population appear to work for people with mental illness. And however, significant barriers still remain to people accessing these interventions, and these interventions need to be more tailored to meet their needs. And we believe there's still a need for studies specifically designed for younger people, because in our study we've got mainly older people taking part, and what we'd really like to do is create an intervention more tailored towards a younger audience to help younger people stop smoking before they're experiencing the ill effects of smoking and experiencing physical health problems and physical health difficulties. So finally, my final slide, any questions? So obviously, if I was here with you now, you know, we could have a nice conversation afterwards. We could discuss the way forward, what we might like to do. But I've just put my email address here. Please do contact me if there's anything you want to discuss or if you have any questions for me. And just like to thank all the participants who took part in our studies, the National Centre for Smoking Cessation and Training for helping us develop the intervention, and everybody else who supported us. And also there's a statement from our funder below there. So I'm just going to now try and stop sharing, if I can work out how to do that, and have I stopped sharing?
Yeah, that's
yeah.
okay, Emily.
Okay, thanks.
That's great, thank you. Yeah, lovely, thank you very much indeed for that. Caught up a little bit of time, but I'm going to ask you the same to pick up questions in the chat if that's all right.
Yeah.
What I would say is anybody that was on the session this morning, Joe Smith presented the most recent NCAP findings, and intervening for people's physical health problems remains an area of development, and would absolutely recommend Emily's work as a fabulous resource for teams that are wanting to help people stop smoking. So thank you again for that. Going to move swiftly onto our next speaker. This is Samuel Turley from the GRIP team in Gloucester. Over to you, Samuel.
Yes, hi, I'm Samuel Turley and this is Laura Bocci, and we've got a small kind of video presentation for you today that we've kind of knocked up just to explain some of the things that we've been doing with our ARMS pathway, or rather around some resources and a kind of pilot project that we've been working on around trying to create something that kind of works better for our ARMS clients compared to what we're doing already. The video hopefully will kind of explain in a quite brief, succinct way kind of what we're aiming for. Okay, so if you want to roll the video. I think that the video has been muted, Taya, so you might have to go back to the beginning and unmute it. Hello. Yeah, there we go. I think you might need to unmute your.
We noticed at Gloucestershire Recovery and Psychosis, we noticed a question that kept coming up around the current provision of ARMS with our service. Most of the concerns around ARMS surrounded 4 key areas: a confusion about what interventions we were and weren't meant to be doing with ARMS, concerns about whether or not it was even helpful for ARMS clients to be under our team, and the amount of time and resources that our more complex ARMS clients could take up. Combined, all these things added up to levels of frustration amongst staff. This caused us to want to look a little bit more closely at the problem and ask, what are the problems we are currently facing with our ARMS provision? Despite there being a very clear pathway, care package and resources for our FEP caseload, what we are meant to be doing with our at-risk mental state caseload is less clear when looking at specific psychosocial interventions or level of involvement in care. Because of this, most of our ARMS clients will receive something between a watchful waiting approach or a full CPA, with clinicians offering everything we would offer to someone on a FEP caseload, but on a much shorter timescale, such as multi-agency involvement and vocational and accommodation support. This lack of clarity also meant that how we all approached ARMS would differ from clinician to clinician. Another concern raised by this due to the lack of clarity is that people would sit within a specialist psychosis service for longer than they needed to without any real benefit. Our ARMS clients were sitting on caseload between 9 and 47 weeks, averaging at around 35 weeks, with it being very clear what level or what kind of support they were having during that time. A big concern around ARMS clients being under specialist psychosis service for long periods is that not only did it expose them to unnecessary stigma, but it also blocked them from other services, such as IAPT, that may be more appropriate or helpful at that time, given the high levels of comorbidity of common mental health problems we see within our ARMS caseload. Also, comorbid emotional dysregulation within ARMS caseload also raised concerns, with fears that the EI approach could actually do more harm than good for those people. There was also the recognition that a lot of our ARMS clients presented with complex social needs, which involved a lot of additional support. The question was, how much should we be getting involved with these kind of things with our ARMS caseload, especially when their mental health needs might be quite low? NICE guidelines do suggest CBT for ARMS. However, with a lack of CBT provision in EI teams, there is a question of whether this limited resource should be prioritised for the FEP clients. Now we've managed to identify the main problems, we came up with an idea. Can we design an intervention that's specific to the kind of experiences faced by arms clients and that's in line with the newest evidence? Something that fits along a pathway with a clear structure and route, and something accessible enough to reduce the need for trained therapist and care coordinator involvement. Something which only took as long as it needed to, reducing the time that people spent in the service. Perhaps what was most important was making sure that we were seizing an opportunity to proactively help people who were struggling, an opportunity that beforehand we were missing. We aim to develop a guided self-help program for at-risk mental state that focuses on arm-specific experiences. We conducted a literature review to find evidence that something like this could even work. We're able to discover that CBTP focusing on specific symptoms such as voice hearing or paranoia had worked before. The hope was that using the continuum model, evidence would suggest that this would also work for the sub-threshold experiences we see in arms. There was also evidence that low-intensity CBTP can still be effective, even on voices, so that with some training, supervision and support, this could be completed by frontline staff, reducing the demand on psychologists and therapists within teams. There was hope then that a similar CBT self-help for arms-specific experiences such as sub-threshold voice hearing and paranoid thoughts could be effective. We developed a manualized program of CBT guided self-help using psychoeducation and modified CBTP techniques that could be completed between care coordinators and their clients. Not dissimilar to the self-help booklets that IAP service uses for depression and anxiety, but this time focusing on the sub-threshold psychotic experiences we see in our arms clients, aiming at reducing the distress surrounding these experiences. The modules also draw from evidence that working on things like self-esteem and feeling safe can also have a positive effect on voice hearing and paranoid thoughts. Structured as different modules or booklets, using initial assessment and development of a problem statement or basic formulation, the individualized program can then be easily determined using a pathway, which will show which modules of psychoeducation and intervention would be appropriate based on the latest evidence. For example, for someone who hears critical voices, the modules containing psychoeducation and CBT interventions for voice hearing will be appropriate, but also the modules on self-esteem, values, goals, and assertiveness. The length of each client's program is individualized based on their need. For some, a program of psychoeducation around their experiences lasting only a short time, after which they could be signposted, referred on, or discharged. Their time under EI services being short but helpful. For some, the program may be longer and contain more complex interventions, this all working towards having clients in EI only as long as they need to be, and that they receive a focused and evidence-based intervention during that time. The added benefit of using booklets is that the client can complete them and keep them and taking ownership of their own recovery. The use of outcome measures also means both client and care coordinator can track progress as the client completes their program alongside their care coordinator. All of the resource booklets are now close to completion, each module touching on a wide range of experiences we see in ARM's caseload, all with a goal at reducing and managing things like voice hearing, paranoid and unusual beliefs, etc., and the difficulties which underpin and maintain them, as well as a manual on how to run the program. We have completed a research proposal outlining the cost of the study and any additional training needs. We recognise that the need for training, supervision and support for the clinicians will be completing the study, and at present, such a training program of basic CBT techniques and the program itself is being developed. As far as evaluating the pilot, we have identified which outcome measures we will be using to be used before and after completion of the program, as well as a plan to redo the CALMs before and after to hopefully show improvement in the client's symptoms and experiences. We also hope to evaluate how the clinicians find the program using a focus group. We are planning to run the program over 6 months and involving all new ARMS cases that come through the service in that time, which should give us a decent sample size. Although progress has been somewhat halted due to COVID-19, we are hoping to start running the pilot this year. It's something that all involved are really excited about. We hope to have some results for you soon. Thank you for listening.
Okay, can you all hear me all right now? Oh, there we go. Yeah, so that was kind of where we're at with it, really. Unfortunately, if we're kind of looking at those last couple of slides, we've done a bit of reflection recently and had a bit of feedback, and we are having to kind of streamline things and have a little bit more of a look at how we're going to integrate it into our service. So we are having another look at what the research proposal is going to look like, and in regards to like the costs and the training needs. So we are kind of redrafting that at the moment. But yeah, so that's kind of where we're at, and I think that the big motivation, I mean, for me anyway, when we kind of first started doing this was, as it said in the video, there was a real gap, I think, for arms provision, and there was people that were coming through our service and it wasn't clear whether they were getting any kind of helpful intervention, or if they were getting an intervention that was pulling too much resource, and or maybe that them actually being in our service was being more harmful to them because of the amount of time they were spending in the service and not really getting anything that was specific to help them. So this was all kind of an attempt really to address that and to help those people in a very specific and meaningful way. And it does, you know, raise a lot of questions that I think that one of our speakers talked about, that Graham talked about earlier, around some of this diagnostic uncertainty and whether, and I think you see an awful lot of that in our arms caseload. Laura, if you've got anything you want to add, really.
I think the other side of it that we're very interested in is what the experience of clinicians delivering this is going to be. So that's the other side that we want to develop. Is this is very much an idea stage, but actually a way of evaluating training people and delivering a low intensity CBT intervention. Yeah, how feasible that is, but again, it's very much at a pilot stage at the moment.
Yeah, but we're hoping to see some good results. So yeah, that's it really.
Are there any questions at all?
Yeah, lovely, thank you. Are you there? Hello. Yeah. Yes, lovely. Thank you very much indeed. That was a slick presentation. That's hopefully made everybody forget how clunky we've been up until now. So really appreciate that. There's a request if you could share your literature review, and I think that question itself highlights just how much interest there is in arms. It's our new frontier. NHS England is going to produce and publish some good practice guidelines this year. A question perhaps to end on, what do you guys think is the optimum length of time that somebody should be on an arms pathway? Can you answer that question if money was no object?
I really struggle with that. I think for me, I just feel like I just don't know.
Yeah.
I think we haven't been systematic in how we've provided our interventions for arms people. I mean, it's varied quite significantly. So for me, I'm really not sure.
No, I mean, just from my kind of professional clinical experience, really, if the time that they're on the caseload is well spent and that specific kind of interventions and things are being done, then I think it can be, well, it's kind of 6 to 12 months, but I think that was the issue we were seeing, is that wasn't happening. So you could argue as short amount of time is possible that they are receiving something that is helpful. And I guess that's what the pilot is to discover, is how short and specific can you make something that it still is actually effective. Does that kind of make sense? Yeah.
I think as well, within EI services, within the EI service in which I work, there's always been a discomfort that we have at-risk mental state people sitting under a service that's for first episode psychosis, and with the kind of variability in the people going on and becoming potentially first episode cases and the quite high false positive rate, I think it's always raised some concerns for people that, yeah, whether or not these people should be sitting under a psychosis service or whether there could be a separate service for people, less stigmatizing for them.
Yeah, I don't know, there are kind of EI teams at different trusts that do have a separate kind of armed service that kind of sits away from the kind of FEP kind of EI service, and I think there are potential benefits to that. I think there's more clarity then in regards to what the pathway is, and it can feel separate and therefore less stigmatizing from that kind of early intervention way of working, and everything that kind of comes with that.
Okay, lovely. Thank you very much for that. And just while you've been talking, a lot of really complimentary comments coming up on the chat bar. Really fantastic presentation. So thank you very much. James, you can try and follow that then. This is our final speaker of the day. James Kirkbride from University College London is going to talk about predicting population need for psychosis in England. This is James's latest work on predicting cases, and that's my telephone going. Over to you, James.
Thanks very much, Moggy, and thank you all for joining us here. Can you hear me okay, and can you see my slides? Great, fantastic. So today I'm going to be talking about using the empirical evidence for that we know about psychotic disorders for predicting future need for care in EIP services in England, using an updated methodology that we've produced over the last 2 to 3 years. So I'll just advance through my slides now. So the background to this is that early intervention in psychosis services require evidence-based forecasts for future need for care to get the resourcing right so that people are in place to provide that care when needed. We know that the incidence, that's the number of new cases of first episode psychosis each year, is quite predictable, and this prediction varies around things like age, sex, ethnicity, as well as local need by area level characteristics, things like deprivation, population density, and so forth. So this can really be used as a model to help EIP planners and providers establish services and resource them according to that local need. And in 2013, we set up an initial tool called SCIMITAR, which some of you will be aware of, which predicted this new caseload for first episode psychosis in England based on the population at risk at the time. And that population was taken from the 2011 census. Since that time, this work has been used to inform both NHS England, PHE, and the workforce calculator that goes into EIP service planning. But as you'll be aware, just from that very fact alone, 2011 was a long time ago now, and so the population level of need has probably changed since then, and our old models were quite static, so we needed to update these for various reasons to forecast need. So we know, for example, that rates tend to be higher in urban areas, in more deprived areas, in more fragmented and more socially fragmented areas, as well as being raised for certain groups from certain backgrounds, including many groups from Black and minority ethnic backgrounds as well, and that variation in need needs to be taken into account. So on the screen in front of you now, you just see a list of the main risk factors that we're aware of from the epidemiological research, which changed the need for psychosis in different populations, including on that list cannabis smoking, of course, which is something that we have tried to factor into our new models. So the aim of this study was to see if we could use the epidemiology of psychotic disorders to predict need for EIP care. We aim to develop a statistical prediction model based on this empirical data, both at individual level risk, so age, sex, ethnicity, as well as risk that occurs at the very small area level. So we're talking about very small neighbourhoods, as I'll come on to show you. We applied this to the English population, and then we forecasted need for EIP care right up to 2025, and we hope to share with you the dashboard that we've produced that will allow you to use these numbers to hopefully inform accurately service planning going forward. Our models were validated against MHSDS data. That data was available for the 2017 to 2018 financial year. We're just going to call that 2017 for the purpose of this talk. And our models have done something new that our old models didn't, and that is not only predicting the number of new first episode cases, but an attempt to predict the extra need for care through EIP services that will arise through people who need either extended assessment or assessment due to sort of arms, as we've just heard about with the previous talk, as well as the additional need from referrals generated simply for suspected psychosis, which when assessed turn out not to be suitable for further EIP treatment, but of course will consume EIP service resource and require signposting and triage to other services. So the starting point for our modelling process was these small area neighbourhoods. These are actually called census merged wards in the government's kind of definition of these geographical areas. And you can see a map of them in England. And for each of these wards, we wanted to predict, based on its local characteristics, its population levels, structure by age, sex, ethnicity, we wanted to predict the number of new cases you'd expect to see in those new wards, and then aggregate that up to a level that was useful for early intervention psychosis teams and for CCGs. Our starting point then after that is establishing how risk varied across these regions by taking a sample of evidence from three major epidemiological studies of first episode psychosis risk in England. These are the Sepia study in the east of England, which you've heard a bit about from Graham Murray earlier, the East London first episode psychosis study, and then 3 centres of the ESOP study, which is an older study now conducted in the late 1990s to establish variation in the incidence of psychotic disorders. These studies included about 1,600 people with first episode psychosis, allowing us to establish precise estimates of risk and how that risk varied by various characteristics, things like age, sex, ethnicity, all the factors in fact that I've just described to you before. Our new models then incorporated additional data known as prior information available from other sources. So not only from those 3 studies, but published evidence from the wider literature could be fed into these models to refine our estimates of risk in England. These additional estimates of risk were identified from meta-analyses, essentially, to sort of help inform estimates by age and sex, by estimates by ethnicity, estimates by cannabis use, and so forth. And on the screen, you just see an example of how we've used cannabis use in England to inform these models. So we know from the Adult Psychiatric Morbidity Survey the proportion of people in England from the general population who have reported ever smoking cannabis. They're shown on the screen, and they're broken down by both sex and by region. And you can see there's a little bit of variance there in how people report smoking cannabis from the APMS survey. And we apply those risk estimates to our population and then apply those to how much increased risk we would expect to see due to cannabis smoking to refine our model estimates. So where does this prior information come from? Well, it largely comes from meta-analysis, from a major review we conducted for the Department of Health a few years ago for age, sex and ethnicity, from a meta-analysis of the risk of first episode psychosis associated with cannabis use, published by Therese Moore and Peter Jones and other colleagues in 2007. And then from other sources of information for things like area level deprivation as well. Once we combine that information from the empirical incidence studies of psychotic disorder with the prior information from the published literature, we then can refine our total estimates of risk, what are known as Bayesian posterior risk estimates. Don't worry too much about that for now, but for each factor, whether it's age, sex, ethnicity, deprivation, we get a kind of average level of risk over all these wards in England. We can then look at different parameterizations of those models. So to break this down simply, we considered 6 different models, and those models just considered different combinations of these risk factors. So for example, model 1 is a model that only considered age, sex and ethnicity and didn't consider the area level variation risk that occurs due to any other characteristic. Model 2 also includes age, sex and ethnicity, but then extends the model to include risk by deprivation and social fragmentation. And our models build up gradually in complexity, with model 5 actually being the most complex, which included everything we could possibly think of, including that extra risk for cannabis use. So we run those models, we then get these risk estimates, as I've said, and we then apply them to the whole population of England. So taking those risk estimates for each model, we apply them to the population structure of England from 2019 up until 2025. Those forecasts of the English population were estimated by a demographer who took the 2011 census data and then estimated for different regions and local authorities levels of change in the population expected due to changes in birth rates, death rates, emigration and immigration, including what would happen under a Brexit scenario, which now seems like sort of yesterday's news given what we've gone through with COVID, but we nevertheless modelled changes in the denominator that we'd expect to find in the population. For each model then, once we've taken our risk estimates and applied them to these population estimates, we can estimate how many new people with psychotic disorder are going to arise in these population areas in each year over that period. We can do this at various levels of prediction. So the biggest level of prediction we could predict to was the number of people referred for suspected psychosis, so the people referred to services. We can then break this down to the numbers of those referrals who are actually assessed by EIP services, which is a subset of that group. Then the number, of course, of referrals who were treated by services, because not all people assessed will be taken onto the caseloads for treatment, as we know. And finally, amongst that treated caseload that are taken on for EIP treatment due to for a first episode psychosis, the number that we think were probable first episode psychosis cases, because we know that after a period of assessment on an EIP caseload, people might not meet diagnostic criteria for a psychotic disorder. And those sort of four concentric rings of prediction, if you like, are just shown on this screen and how they're defined. The change from treated first episode psychosis to probable first episode psychosis was adjusted down by about 14% based on empirical evidence that we published from the CPIA study in East Anglia, that about 14% of people treated in EIP services in East Anglia during that period of the study were found not to meet clinical diagnostic criteria for psychotic disorder. For our predictions then for the year 2017, we then compared our predictions for probable first episode psychosis to what we saw through the MHSDS data for the same year, and compared each of our 6 models as to how well they fitted that observed data. And that's the results I'm going to take you through now. So we're just going to be focusing for the next while on this probable first episode definition. We'll come back at the end to see how that affects additional need at other levels of service care. So on the screen, it's a bit of a complicated table, but what you'll see is that in 2017 and 18, in that 1 year period in the MHSDS, we saw just over 8,000 people who were defined as having a probable first episode psychosis. And our models then predicted various numbers around this. The model that predicted most closely to this number was model 4. This is a model that included predictions by age, sex, ethnicity, deprivation, social fragmentation, that's an area, a sort of area level measure of isolation in the community, as well as cannabis use. And that model predicted 8,112 cases, so only 74 cases more at a national level than what we observed in 2017. We can then look at that model in more detail to see how well it performs by different socio-demographic characteristics. On the far left, you'll see that total being very accurate in red compared to the observed number in blue. For young people aged 16 to 35, our model in red tended to underpredict the observed number of cases, whereas for 36 to 64-year-olds, our model tended to overpredict slightly. So our model's a little bit off, and all of our models were a little bit off on age. They tended to underpredict for young people and overpredict for old people, perhaps as a function of the underlying data. But for men and women, we got the predictions exactly right, as you can see. And then for ethnicity, after accounting for some missing data in the MHSDS, our ethnicity predictions by major ethnic group were fairly accurate as well, as you can see on the remainder of the screen. We can then drill down a little bit more into this model and look at how well our model performed at the CCG level. So although we predicted at these very small electoral ward levels, we then aggregated our predictions up to CCG level, which we thought would be most informative for service providers. And you can see how well our models predict. Now, these are a bit technical details of model fit, essentially. But if we just focus on model 4, which was our sort of candidate best model, this model had a very good internal fit to the data, and then it had the lowest level of error, which is measured by the RMSE, and the highest level of correlation between the observed and the predicted cases of all of our models, although they all performed fairly similarly. So we've decided to take model 4 as our best fitting model at the national and CCG levels. And from that model, we can compare the data and how they fit to the observed MHSDS data. So on the screen, you see observed cases of first episode psychosis in England in 2017 for each CCG region. That's compared to our predicted numbers for that year. And just visually eyeballing those two, you'll see that there's a striking degree of correlation between the two, which shows that our model has relatively good prediction at the CCG level. We can also, of course, express that number of new cases of psychosis not only as a count of cases, so the actual number of cases each CCG should see, but an expression of that as an incidence rate, so the rate per 100,000 people per year. When we express that as an incidence rate, taking into account the fact that some CCGs cover more densely populated and urban areas, what we tend to see are the highest rates of disorder occur in our most urban regions or urban CCGs, those in central London, in Birmingham and the Midlands, as well as pockets of high rates around Manchester and Bradford in the north west. So I said I'd come back and return to not only what our model predicts for probable first episode psychosis, but what that means for additional EIP service resourcing. And on this slide, you can see the year-by-year comparisons for probable first episode psychosis in blue, which stay at around 8,000 to 9,000 per year in England. And then the additional levels of people who will be assessed by EIP services, not accepted as it says on the screen, I should say assessed, I apologise for that. So about 22,000 people will be assessed for possible entry to EIP services, but only about 8,000 to 9,000 in England will be taken on. And of those 22,000 people assessed, that will be generated from up to 24,000 people being referred for suspected psychosis. So the difference we see there is at the stage of assessment, where most referrals to EIP services will not be taken on for assessment, but need to be signposted to other suitable services. So I hope I've shown you in this slide, in this talk, that the knowledge of first episode psychosis incidents can predict future need. Our new models use small area variation in risk, much smaller than before, to predict that need. We hope that they'll be able to assist service planning with more accurate information about expected need up to 2025. I should say that between 2019 and 2025, we expect that increases in incidence to be about 6%, about 1% per annum, although this work was conducted prior to COVID, and we don't quite know what the impact of that will be, because we know that some particularly socially disadvantaged groups might face more stresses as a result of the inequities that followed COVID, the COVID pandemic. Our models now predict not only first episode psychosis, but that additional level of need that occurs through treatment, assessment, and referral to EIP services. As I sort of says the same thing there. We'll publish this information as a freely available tool, which I'll just show you a screenshot of shortly, and that information will be broken down by major age group, by sex, and major ethnic group, so service planners can begin to get a handle on not only the numbers who will be treated for psychosis each year, but the sociodemographic characteristics of those. This data will be freely available on our new SCIMITAR dashboard website. It's currently, this model is currently being considered for peer review in an academic journal, so we're reluctant to release the data until that's been done. The website is there, but if you go to that URL, I can assure you that you get a dead end at the moment, but we will be releasing that data as soon as we can. Just an example of the dashboard and how it will now look. This will be a sort of a version of that dashboard that you'll see, and for any given CCG, you'll be able to look at the numbers of new cases that we expect to see per year, and you can tailor that to be broken down by age, sex, ethnicity, or change the prediction from referrals or assessed cases or people with probable first episode psychosis as you need for any year up to 2025. So an enormous amount of work has gone into this tool, particularly from the team at UCL and from other members of the research team, including Paul French and Peter Jones. I'd also like to thank the colleagues at NHS England, many of whom will probably be on this call, Jane Nairn, Carl Money and Amy Clark, who have been really extremely helpful in allowing us to triangulate our predictions against the NHS DS data. So if you need to get in touch, my details are on the screen. Otherwise, I think I'm just about out of time and I will stop sharing my screen. So thanks very much.
James, thank you very much indeed. Really impressive stuff. That's the second chance I've had to see it, and I like it better every time. The questions that have been coming up, not surprisingly, are ones that you will have heard many times. Why does it not quite reflect what we experience exactly where we are? A little bit like I was complaining about the weather forecast for Yorkshire not being accurate for my back garden. But I'll let you pick up some of those questions. I think the other question that you did refer to, but I think is interesting, a lot of people. Tim this morning talked about a mega recession that's on the horizon following COVID, and we're all worried about that. Will you be able to go back into your model and make adjustments when we can see what the impact of COVID has been?
Thanks, Moggy. Yeah, we absolutely will. It took about 2 years to get the modelling right, and just when we finished the modelling in December 2019, COVID occurred, which will no doubt change some of the parameters. So we've designed the model though so that we can update it iteratively as new data becomes available. So once we know a bit more about the landscape of inequalities and deprivation as they emerge from COVID-19, we should be able to update the parameters on things like deprivation or social fragmentation or inequality to reconsider how those are affecting our predictions going forward over the next few years. We've also had to base the model on the population estimates from 2011, but tailored for changes in birth and death rates in England and emigration rates in England. But obviously, when the 2021 census is conducted and then subsequently published, we'll get much more accurate information about the population at risk then as well, which will again allow us to sort of reconfigure our models. So the predictions will be, future predictions will be released to update at various stages according to when new information becomes available. And I totally accept the point that that the models are just predictions. They are predictions of what we'd expect based on a narrow set of demographic and economic and environmental criteria. And of course, with any prediction, there's error around it. So each of our predictions comes with a level of error around it. So if we predicted 100 cases for your area, that would come with some uncertainty, and it might be from 80 to 120. And sometimes that uncertainty won't be enough and you'll see 70 or 130 cases. So they are predictions and they always contain error and uncertainty, but we hope they are more useful than any kind of ballpark estimate that might have been previously available would have given.
Lovely. Thank you again, James. Really good. Thank you.
Thanks.
So we're on the home straight, folks. It's my job to end this afternoon's conference. I hope you agree we've had a fabulous and eclectic range of presentations. You will be able to have the slides. You will be able to continue to ask questions and get replies. So continue to engage with us. Particularly want to thank Sinead, Taya and Steve from the Royal College who've put this together. This is new to all of us, isn't it? I don't think we've done bad. I hope next year that we can see you in person, but perhaps this is the way to allow more people to take part. So thank you to them, and again, thank you very much to all our speakers. Now, I did want to end today's conference with some reflections. Next slide, please, Taya. There we go. There's a picture illustrating reflection. Yeah, some reflections really. We have come through an extraordinary time, haven't we? And I guess next slide, please. you'd expect me to be reflecting on the COVID pandemic and the lockdown period, and I will. I think early intervention teams have excelled and really performed above and beyond the call of duty to keep their services going. That said, we've heard people telling Rethink that they feel that they've not had as much care during this period. We know that's got to be the case. It's not easy to deliver the kind of interventions that we provide digitally, but I think we've done a really good job, and I hope as lockdown eases, we really can return to a much more normal model. But no, the reflections I really wanted to focus on for the rest of this afternoon was actually the last 35 years, which is quite a long time. Why 35 years? Well, back in 1985, exactly 35 years ago from now, I was dropping out of university and dropping into nurse training, and with the benefit of hindsight, probably one of the best decisions I ever made. Next slide, please. Now, for some of you, 35 years ago will seem like a long time ago. For some of you, it won't seem long at all. Some of you probably weren't even born. But some might say not much has changed. So some things are similar. We in 1985 we had a blonde, eccentric, Eurosceptic Prime Minister, Tory Prime Minister. Next slide. In 1985 we had a really unlikely President of the United States. Next slide. In 1985 we were in the grip of a worldwide pandemic. Next slide. And in 1985, we protested about police brutality against black people. Next slide. In 1985, powerful people were exploiting vulnerable people. But some things have improved. For example, I am 4 stone better than I was in 1985. Next slide. And I think we've come a long way in mental health services. In 1985, the general view was that psychosis was congenital and degenerative. Next slide. Now we recognise the impact of trauma, of racism, of poverty, and these are not extreme views anymore. These are mainstream views. Next slide, please. So mainstream that this is what NICE has to say about the impact of trauma on psychosis. Next slide. In 1985, it took between 1 and 2 years to get help if you had an episode of psychosis. Next slide. We now have standards for people to be seen within 2 weeks of referral. Remarkable. And 75% of our services achieving that, we heard this morning. We also have standards for people with at-risk mental states and a fabulous presentation from GRIP showing that this can be done and that we can help people with suspected psychosis. Next slide. In 1985, hospital, asylum, long-term institutional care was the norm. Next slide. And we were prescribing and administering heroic doses of antipsychotic medication. Next slide, please. We now have standards for best practice prescribing, and we've had a great talk this afternoon about the careful use of medication. Next slide. In 1985, behaviour modification was considered the forefront of non-medical intervention. This was generally, in my experience, cigarettes as rewards for adaptive behaviour. Next slide, please. And talking therapy wasn't even a first-line treatment for depression in 1985. Now, adults and families are given evidence-based psychological interventions routinely. Next slide, please. And in 1985, everybody smoked. What a great talk this afternoon from Emily about how we can help even the most hardened smokers stop smoking. In 1985, everybody smoked. Next slide, please. And not just smoking, physical health of people with serious mental illness really does matter. Next slide, please. 1985 saw the peak of post-war unemployment. I think it reached 12% just before the start of 1985, the highest level it's been since the war. 12% unemployment of adults, whereas at the time, less than 12% of people with schizophrenia or psychosis had any kind of meaningful employment. Now, we have standards again. Yeah, please, next slide. We have standards for helping people return to valued work roles. Next slide, please. In 1985, carers did not matter. Next slide. Now we offer them support, education and therapy. Next slide, please. In 1985, suicide rates for people with psychosis and schizophrenia were at least 15%. Next slide, please. We now aim to keep suicide rates below 1%. Next slide. So we really have come a long way. And I think, hold on, I think the NCAP results that we were given a sneak preview of this morning shows that the progress we're making, we really do have the highest standards for the care and treatment of people with psychosis in this country, and to see the numbers of teams starting to achieve the levels of practice required for that standard is really impressive. So we really have come a long way. Next slide, please. But what about the future? Well, in another 35 years' time, next slide, please. It will be 2055. Next slide, please. And I will be 90 years old. Look at that. Going to stay good looking all the way to my death by the look of things. Next slide, please. So these are my hopes for the next 35 years. Clearly, it's a lot to ask, but I think those drivers of psychosis and ill health and disability are within our grasp. These are the things that we can change in the next 35 years. And I hope that means that by the time we're at the EIPN conference in 2055, we are absolutely talking about prevention, because that will be the norm. There will be a whole new generation of clinical evidence. Sustained recovery with the kind of meaningful outcomes that you would want for yourself or your children will be the norm. Recovered service users will be an accepted and natural part of our workforces, and ordinary lives will be the outcome for everyone. Next slide. Okay, so that's my little reflection back on the last 35 years. I hope that's entertained and informed. I'd like to just end in the next couple of minutes on some adverts. So next slide, please, Taya. We recommend that you join the EIPN accreditation program. So this is the EIPN annual forum. This morning there was a presentation from Steve about what it requires to join the actual accreditation network. Have a look at that, get in touch, but I genuinely recommend joining the program. Early intervention teams have a lot to gain from joining this program. Next slide, please. Yes, and I wanted to finish on an advert for the Voyage of Recovery. You may remember that this was meant to be taking part this summer. We've got 8 teams currently that were lined up to take part in a partial circumnavigation of the British Isles, taking crews of service users and staff out to sea for extended periods on tall ships like the one shown. Next slide, please. So because that's had to be postponed to next year, there is an opportunity. We'd like to increase the number of crews up to 10 or 12. This really would give us the chance to fully circumnavigate the British Isles next summer. If you're interested, you need to be able to get together 15 crew members. That's approximately 10 service users and 5 members of staff. There will be 3 permanent crew on the ship. You'll be sailing a 6-day leg of that round Britain trip. 50% of the cost of the voyage is funded by the Surden Trust, which is a charity, but it does mean you've got to raise some funds yourself to take part. But if you're interested at all, contact Mike Jackson at that contact number, which we'll leave up. And I'm going to end today with a final thank you to everybody that's helped make this event a success. I think we got away with it. And Tayat, can you just show the slides for the pictures of the previous voyage? So I'm going to sign off there, and I think I can make myself disappear. But thanks again. Keep in touch. Continue with the conversation, and we'll see you again, hopefully in person next year. Thank you.